with people in the emergency departments boarding, waiting for beds, staff sidelined either in isolation or quarantine because of documented cases of COVID-19 or significant exposures, testing overwhelmed, not available, slow turnaround time, and that even includes not being able to buy rapid antigen tests. So this is a huge challenge for us. So having said that, I'll get to the numbers. Our 7-day average of new cases in Wisconsin is almost 11,000 and rising rapidly. Just to put that into perspective, our highest single day count back in November of 2020 was only 7,989. So we're in unprecedented territory in terms of new cases. Case positivity rates are incredibly high at 29%, meaning that we're just not testing enough people. There is a huge burden of undiagnosed disease in our community. And the reproductive number is over 1, meaning that the pandemic is expanding and not contracting. Next slide, please, Chelsea. Our 7-day average of daily deaths has been holding steady for the last 3 months, obviously too high. It's been running in the upper 20s, but we have not yet seen an increase in deaths from Omicron. Hospitalizations are at 2,219. This is as of last Friday. And we actually exceeded the total hospital count last week that we saw at the peak of the COVID surge in November of 2020. We also surpassed our ICU records at 479. It was up in the 480s last week. And our hospital occupancies remain incredibly high. 92+% of every hospital bed in Wisconsin is full, with 95% of our ICU beds occupied. And just recall, we've talked about this before, hospitals work best when beds are in the 75 to 80% full range and when ICUs are in the 70% full range for lots and lots of reasons. So we are now in territory that is incredibly inefficient for managing the beds. And this is at a time when we have a lot of staff sidelined, either with COVID-19 or because they've been exposed and they're in 5-day isolation or quarantine. So this is a huge, huge challenge for us. And this has been going on now for 3 months. Delta strained our hospital capacity. And as it was supplanted by Omicron right around Christmas time, we didn't really see any relief from this less severe strain. So this is really, really a challenge for us. Now, I do want to disclose only 24% of Wisconsin hospital beds are occupied by COVID-19 positive patients, but that still is a problem for us because people are getting sick from other illnesses, and they also require care. And having a high burden of COVID in your hospitals just complicates the clinical care environment. We also have seen that even though Omicron is milder on a population basis, it is not mild for people that are sick enough to come into the hospital. And in fact, almost 1/3 of the people in the hospital with COVID-19 are on ventilators. So this is a serious challenge for us. The next slide, please, Chelsea. Just some numbers. You can just see how things have changed over the last 3 months here. Cases skyrocketing, new probable but not PCR confirmed cases skyrocketing, percent positivity skyrocketing. But then looking at the bottom on the right, you can see that our deaths, daily deaths as a 7-day average, have not yet begun to rise. The next slide, please. This is a picture that I like to show that shows the burden of disease in Wisconsin's 72 counties over time, starting with the peak of the November 2020 pandemic, where virtually every county was at a critically high level, with a handful at very high levels. We started vaccinating people in January, and the surge began to abate very significantly, and we were doing great right around the 4th of July of last year, and that's when Delta hit us. It caused about half of our counties to be critically high at the highest point, but we're in new territory again with Omicron. As you can see, for the first time in the history of the pandemic, every county is at a critically high case burden level. Next slide, please. So I just want to leave you with a few points about Omicron. What do we know? We really have less than 2 months of experience with the variant here in the United States, and we just learned about it from South Africa the day before Thanksgiving. So we're learning more every day. As I mentioned, the case counts are massively increased due to the explosive transmissibility of this variant. It is on the order of contagiousness as measles, which previously was thought to be the most contagious virus that we were dealing with. And recall that Delta was on the order of magnitude of transmissibility of chickenpox, which was very, very significant. This is just orders of magnitude more transmissible. So what I want to say is our case counts still matter, but only in the context of a broader set of metrics. We really need to track hospitalizations, hospital capacity, and deaths. And those are things that are still evolving. So I would say that within a few weeks, we will be able to reconnect the relationship between cases, hospitalizations, and deaths. But those have been disrupted by the emergence of this very different variant. So we know that cases of Omicron are about a third to a half as likely to result in hospitalizations and death as cases of Delta COVID-19. But this is still a significant challenge for us, especially since everyone is getting sick in a short period of time. And a substantial percentage of hospitalized COVID-19 patients do have, what I would say for the first time in the pandemic, a meaningful difference between hospitalized from and hospitalized with COVID-19. 40 to 50% of the people in hospital who have COVID-19 were detected when they were admitted for some other reason. But I want to make sure that you know an incidental finding of COVID-19 does not mean insignificant or trivial. And indeed, Omicron complicates the clinical care environment. It exacerbates comorbidities. It increases the morbidity and mortality of people that were admitted with non-COVID-19 diseases for both systematic reasons and for individual susceptibility reasons. So this remains a very significant challenge for us that I've already heard many people marginalizing the significance of Omicron, oversimplifying by saying that it's milder, and a lot of the people in the hospital that have been diagnosed with it aren't in the hospital for Omicron, but it is still a challenge for us. Next slide, please. What do we know as of today about Omicron? Well, first of all, you can pronounce it many different ways. They're all valid pronunciations. But it has 4 mutations that really jumped out of a background that we hadn't seen since early in the pandemic. Many of these mutations are known to make COVID-19 more transmissible. There are significant changes in the sequence of the spike protein. And because of the burden of those different changes of the protein, it raises concerns about immune evasion because previous infections and our vaccines are targeted at that spike protein. It's been detected, and it actually is the most prevalent variant in every US state, many countries, most countries of Europe, and some in Africa. And it has virtually extinguished transmission of the Delta variant in South Africa, Europe, and the USA. We're sequencing far less than 1% of any other variant right now. And as I mentioned, it's much more transmissible. Now, some things that you may want to know, thinking about the health and well-being of your community. Previous COVID infection with alpha, beta, or delta strains, or the so-called natural immunity, and vaccines provide less protection against Omicron than they did against previous variants. But what we do know is that full vaccination status and boosters provide very significant and meaningful protection against hospitalizations, severe disease, and death from Omicron. So our main line of defense is still encouraging vaccination. Unfortunately, natural immunity doesn't do such a good job against Omicron, and I'll talk about that on the next slide. So the incubation or latency period of Omicron is much shorter than when compared to the other variants, and this poses a lot of challenges about testing, what we thought we knew about COVID-19 before. So Omicron's incubation period is about 2 days versus the typical 5 to 7 days with the previous strains. The doubling time in populations is astonishingly fast, 2 to 3 days, especially in the rising portion of the COVID curve. And this is for 2 reasons. One, it's very transmissible on an individual level, and that latency period from exposure to symptoms and then contagiousness is very, very short. The symptoms also have changed very significantly from the other strains. They're primarily bronchitis and upper respiratory symptoms instead of systemic and pneumonic or lung symptoms. So you're going to hear people presenting with a cough, a stuffy or runny nose, headache, scratchy throat, and severe fatigue. Very, very different than the constellation of symptoms that we've been dealing with before, and unfortunately much more difficult to tease out from a garden variety cold or the flu, which is also circulating now. The symptoms also seem to resolve more quickly than previous strains, and although there is very significant variability, people seem to be less sick with Omicron than with other versions of COVID-19. But this is predominantly a statement that I can make with certainty for vaccinated individuals. Unvaccinated people are actually faring very poorly with Omicron, even if they have had a previous infection. And we know that vaccines are less effective, but still pretty good. Monoclonal antibodies, unfortunately, are not working very well against Omicron, and that previous infections with COVID-19 give a significantly reduced, maybe just a modest protection from subsequent Omicron infection. Interestingly enough, laboratory studies suggest that if you're infected with Omicron, you're going to have pretty strong protection in the future from a reinfection with Omicron or with any of the older strains that were circulating should they re-emerge. Again, though, this needs to be demonstrated at a population level. These are simply laboratory studies. The next slide, please. So what's next? Early on, there was some optimism right around Christmas and New Year's that we would be fortunate and to have similar outcomes as we're seeing in South Africa. So what you see on this slide is South Africa's 4 waves, and the one on the far right, past that horizontal bar, is the Omicron wave with lots of cases, not quite as many cases as they had earlier with the Delta wave, and virtually no deaths. And I show that, highlight that in the red circle on the right, and a very rapid increase and a very rapid decrease in case counts. But what I want to make sure everyone knows is we're not South Africa. South Africa had a burden of many repeat infections, so-called very strong natural immunity, and a very young population compared to Europe or North America. So let's see on the next slides what's happening here. So these are the aggregated US data. You can see on the far right the enormous case burden that started in December with Omicron when it overtook Delta. And you can see that hospitalizations down in the middle at the bottom started to go up. A few weeks later, there's about a 3-week lag in or 2-week lag in cases and hospitalizations. That's actually shorter than we saw with the other variants. And then look at the far right on the bottom, deaths, just now starting to increase. And this is what we would expect based on what is being seen in Europe, especially in the UK. About 3 weeks after the surge in cases, we started to see an increase in deaths. And in the interest of full disclosure, the deaths did not rise in the UK as much as they did for previous strains, although we already had a significant burden of daily deaths from the Delta strain. And what I would say is we're probably right at the tail end of people dying from Delta. And we're at 3 weeks in Wisconsin. So we would expect if there's going to be a significant uptick in deaths, it's going to happen this week. Maybe we'll learn a little bit more when the data come out this morning, because as you know, the state does not report data over the weekend anymore. And in fact, there are reporting lags on Monday and even on Tuesday. So next slide, please. So these are Wisconsin data pulled from the New York Times yesterday. And you can see that we still don't have deaths. So if you look at the top slide, no increase in deaths in the circle that I've highlighted there, despite a slow uptick in hospitalizations on a very high baseline and a skyrocketing number of cases. If you look at the states that are about a week out from us, ahead of us, you can see there is evidence of peaking in Massachusetts, especially Boston, in New Jersey and in Washington, D.C. But at the same time, their reported deaths are starting to go up. So we're about a week behind them. They're 4 to 5 days into seeing a spike in deaths. So again, as I mentioned, this week is really going to be seminal for us in understanding what's going to happen here with Omicron. The next slide, please. I just want to say thank you and be happy to answer any questions.
Thank you, Dr. Raymond. As always, incredibly informative. We have a question that came in. Do you have to test again after 5 days of being symptom-free if you have had Omicron or any variant, or is that optional? There seems to be a lot of confusion as when can you go out again? When can you be safe to be around others?
For people that tested positive but are asymptomatic, the CDC guidance still remains no need to test. Or if you've been exposed and you're quarantining after 5 days, no need to test if you're asymptomatic. I'm not sure, and many experts aren't sure that this is the best guidance. If you think about the biology of the disease, it comes and goes quickly, but we don't know for sure that 5 days out, especially if you were symptomatic, that you're not still contagious. In fact, there probably are some folks that are. This is just simply an acknowledgement that tests are hard to come by. People are fatigued and tired of lockdowns and isolating and quarantining, and that many people weren't doing it anyway. So again, I'll just stick to the CDC guidelines, which are 5 days out from a symptomatic infection that is PCR confirmed. If you are asymptomatic, you don't need to test. You can stop your isolation.
Great. Our next question is regarding vaccinations. What if you got one J&J and then the booster? Is that the same as 2 of either Pfizer or Moderna and a booster?
It's pretty good. So we'll say there, the comparative studies are hard to come by, especially now with Omicron. There's there's not enough experience for us to say. But what we do know is that if you received a booster from J&J, which would be your second shot, and you received it recently, your immunity is pretty strong. If you received an mRNA booster after getting the one shot J&J, it's probably even better. The one caveat I would say is that J&J was one of the predominant vaccines that were distributed in South Africa, and they say that people fared very well with Omicron, with the J&J. On the other hand, they fared really well compared to what we're seeing in Denmark, UK, and here in the US. So I would just take that with a grain of salt.
Our next question is, do we have any data on comorbidities and death caused by COVID specific to Wisconsin?
That's a good question. I actually published a paper with some other colleagues at MCW that talked a little bit about comorbidities, but that was with the first and second waves. It's been pretty consistent in every country and every state that the comorbidities that matter are the ones you already know about: diabetes, cancer, kidney disease, obesity, hypertension, other heart diseases. Those are the big ones. And lung disease, pre-existing lung disease, at least up until Omicron, was also a predisposing factor. Age, over 70 in particular. I don't think that there's a lot of variability with those, but we're still learning about Omicron.
Dr. Raymond, are you seeing an increase in hospitalizations due to influenza?
Yes. And there are people that are co-infected with influenza and COVID-19. It actually is complicating some of the narratives about COVID, because we want to be careful with people that are co-infected, that you don't necessarily attribute a bad outcome just to COVID.
Our next question here is, some are claiming that hospitals are reporting people that have 2 shots but have not been boosted as being unvaccinated patients. Is that true?
Not to my knowledge, but most of the health systems that I know have a pretty standard reporting procedures that are consistent across the board. Could somebody have made a mistake? Sure. And that's sort of how these social media disinformations begin. But the reporting is very consistent across the country. If you're fully vaccinated, you shouldn't be reported as unvaccinated.
That is all the questions I am seeing. Chelsea, is there anything in the Q&A that we've missed or a call in?
Nope, looks good here, and I don't see any raised hands at the moment. Oh,
Okay.
one more came in, I see.
Oh, here we go. Last one, Dr. Raymond, if you have time. How is the variant info collected to know that this is all Omicron and not still some Delta variant when we are told our local testing doesn't test for the variant unless specifically requested?
Yeah, well, the state hygiene lab actually does representative sampling from all the counties, and they do sequencing, full sequencing of the variants. It's a small sample, so you're certainly extrapolating to a large population, and there's always, some danger in doing that. But look, pretty much every community in the U.S. now has Omicron, even out west, where it's about a week behind us. It is by far and away the dominant strain.
All right, I think that concludes all of our questions here on our end. Dr. Raymond, you are a tremendous resource to Wisconsin counties. You're always so willing to join us for our morning calls. We greatly appreciate it. As a reminder to all attendees, Dr. Raymond, we've recorded this presentation. We will post that to the WCA website along with the slide deck that he just presented on. So again, thank you, Dr. Raymond. We so appreciate your time today.
Thank you, Michelle.
All right, with that,